button? Have you seen it?
It's not part of my own button.
Okay.
I'm saying
no problem.
There's no issues with that.
yeah.
So,
I'm saying
right at the bottom, you will see just beside reactions, you will see a box with arrow up, share.
no, I do share presentations before now, so I would have seen it. I've been searching for, but I did not see any arrow up button.
No, we're trying to say that it's under the caption with more, with the 3 dots. So if you click on it,
I clicked on more and I'm seeing
yes.
and I'm seeing reactions, captions, setting, stop incoming videos. Those are the
Okay.
options.
Okay, not a problem. Dr. Lopade, if you would assist her.
Can you see?
Yeah, you just have to expand it. Then you just keep scrolling up. So you expand it to like maybe 80, 100%. I don't know the percentage that is showing you right now.
It's not showing me anything because the moment I share, it's difficult for me to expand.
Okay, let's just we cannot see it, right?
Yes.
Can you see it?
Yes, I can see it. So you just help me scroll up.
Okay, so I can. Okay.
All right. I want to thank everybody in EMSON for this opportunity. Thank you so much. I'm Olajumoke Oshosonya. I'm the lead dietitian at Cairo Diet Clinic, and the topic today is the 8 billion reasons to heart. So let's go to the outline. So of course, we're going to talk about the 8 billion context, beyond calories in and calories out. Prof already talked a bit about the beyond calories in and calories out. Then we're going to move on to the reasons to heart, medical nutrition therapy, evidence-based reviews, the multidisciplinary approach, conclusion, questions and answers. Now, overweight and obesity are defined as abnormal or excessive fat accumulation that presents a risk to health. A body mass index of anything above 25 is usually considered as overweight, and anything above 30 is considered as obese, being obese. But we already know that the scale or BMI does not tell the full story. So your BMI cannot tell you your bone mass, your muscle mass, and that is why we have other indicators. We're still going to discuss the other indicators. So there are 2.5 billion obese adults globally, according to the World Health Organization. And we have 8 billion reasons to heart. According to the World Health Organization, 1 in 8 people in the world are currently living with obesity. That's a total of 2.5. No, I'm still in that. I'll soon summarize it. That's a total of 2.5 billion people, and that's it's 90. Sorry, 1 minute. Okay, sorry about that. I had to mute my phone. Right. So it's 90 million people are living with obesity. While we have people that are 2.5 billion adults are either obese or overweight. Now we have 39% adults in Nigeria, according to the International Diabetes Federation criteria, that are obese, that have central obesity. And that translates to 46.8 million people. 8 billion means the entire world. That's the world, that's the World Obesity Federation telling us that it will touch everybody if we don't act. It's just a matter of time. If we don't understand or fully grasp the concept of obesity, it's just a matter of time to touch everyone. Obesity is considered a disease. I won't talk much about this because previous speakers already touched on it. It's considered a disease, and of course, accumulation of excess fats. It affects the overall body parts, your heart, it can result in type 2 diabetes, heart disease, stroke. Next slide, please, because of our time. I can see they are trying to hurry me. All right, so the question is, am I obese? We are all used to the concept of body mass index. Of course, we already talked about the fact that anything above 30 means obesity. Then the waist to hip ratio is another way to double check. There are some people that will say, I'm not obese. It's my bone that is weighing on the scale. So how do you know if it's your bone weighing on the scale or if it's your fats weighing on the scale? So the waist to hip ratio help to double check. So if you have a waist to hip ratio of more than 0.8, it's more than 0.85 as a woman, that means that you are at risk of chronic conditions and you're obese. If you have a waist to hip ratio of 0.9 and above as a man, that means that you are obese or you're at risk of metabolic syndrome. Another way to check your full body composition is through the bioelectric impedance analysis. That's a full body composition analysis. This will actually show you your bone mass, your muscle mass, your fat mass, and it will just give you a complete picture of your body composition. So those are ways to actually double check if you're obese or not. Of course, we have the MRI and the CT scan. Yeah, moving beyond the scale. According to National Institute of Care Excellence, it actually recommends that before obesity treatments, there are some other factors that should be, that should be put in the picture, and that is your waist circumference and comorbidities. So looking at this table, you see that there is the BMI classification on the left, and towards the right, you have the waist circumference, and then you have the comorbidities present. And for each of it, you see scores. These are scores. When you add them together, it will determine the routes of treatment according to NICE recommendations. So being overweight and having low waist circumference, that's a score of 1. Being overweight or obese and having high waist circumference can be as high as 4 score. So you can see on the screen that somebody can actually have up to 4 score, or someone can actually have 1, 2, 3. So if someone has 1 score, that is general advice on healthy weight and lifestyle. This is based on NICE recommendations. And if it is 2, that's diet modifications and lifestyle intervention. If it is 3, that's diet, physical activity, and there could be indication for medications or drugs. If it is 4, that's diet, physical activity, drugs, and the person may have to consider surgery. Next slide, please. So we also should touch briefly on metabolic syndrome. If someone has 2 or 3 and above of these conditions, then that means that the person have metabolic syndrome, elevated waist circumference, elevated triglycerides, reduced HDL cholesterol, elevated blood pressure, elevated fasting glucose. This can also point to the fact that this person is obese or this person is at risk of chronic conditions. Next slide, please. So what are the root causes of obesity? I'll just touch on it a bit. I'm pretty sure previous speakers already touched on it. Genetics play a huge role in obesity. Lots of research already show us that 40 to 70% is attributed to our genetic makeup. Our genetic makeup determines how we add weight, how we respond to even the food that we eat. And that's the reason why 2 people can be eating the same way. 2 people can be eating the same way, and one person will consistently grow fatter, while the other person will not even feel it, or the other person might even be complaining of adding weight. So genetic makeup has been shown to account for 40 to 70%. And then we have the biological mechanism. The human body has inbuilt mechanism to protect itself from starvation. So basically, our body tries to be energy efficient. I'll still touch on it in the next slide, so I don't want to talk too much about this particular one. For food, Prof already talked a lot about how our environment shapes us, the fact that we now have access to lots of ultra-processed foods. We see them every day. The advertisements show them to us. So that's about the change in our food system. And then we have life events. Prof touched a bit about this, women eating for two, prenatal life. Basically, women especially gain weight during pregnancy. Most women, that period of pregnancy and lactation, that's the time that they gain weight the most. For some women, they have gestational diabetes, and then they end up having diabetes later in life. For some people, they have pregnancy-induced hypertension, then end up having hypertension later in life. So that life event is a big deal for women. And then some studies also show that mental disorder can predispose to obesity, like for people that are under some medications related to mental health, that can actually predispose them to weight gain. And then we have healthcare access. So for instance, if somebody is overweight and the person does not even get enough information or accurate information. So when someone is overweight, there's the part of not even knowing that you're overweight. There are some people that they don't even get to know that they're overweight until probably their trouser does not fit them anymore. An average Nigerian does not have a weighing scale, a bathroom scale in their house to check if their weight is okay or not. So lack of access to healthcare professional at the time when you're overweight, that's the time you're supposed to talk to a dietitian or even find out. So we trivialize food a lot, right? We don't see food as a big deal. So we don't see food as something that can kill us later due to probably excessive intake, So we underestimate the power of what we put in our mouth, right? So lack of access to healthcare professionals like dietitians at the time when you're just overweight, when you're not yet obese, is another thing that can determine if you're going to quickly roll over to being obese or not. Next slide, please. So beyond calories in and calorie out, I already talked about the fact that Prof explained a lot about our environment, how our environment shapes us, And then we have the biological aspect. Our body, like I said before, is energy efficient. That means that when you try to lose weight, you are losing fat cells, Normally, the higher your fat cells, the higher your leptin. Leptin is a satiety hormone. So when you're trying to lose weight, your fat cells gradually reduces, and of course, your leptin will reduce. Your ghrelin, which is the hunger hormone, will increase. So basically, while you're trying to lose weight, your hunger hormone is basically working against you. So you're feeling like you're starving, you're craving lots of food, especially when your plate is not balanced. So that is where you now see a lot of people struggling. They tried one dieting today and then they're dropping it tomorrow because they cannot bear the starvation. They are always feeling hungry. That's the ghrelin hormone working against you. Then there's the issue of the leptin resistance. Prof explained this a little bit. Of course, for leptin resistance, it means that you have so much fat cells that the signal from your brain to your gut is no longer straightforward. It's no longer active. It's no longer efficient. Your brain is not actively telling your gut that you are not satisfied. So some people, they just keep eating and eating and they don't just feel satisfied. So that's what we call leptin resistance. And then we have, of course, reduced GLP response, elevated ghrelin, I already mentioned that. And of course, reduced hormones, other satiety hormones. On the right side, you will see the diagram that I put there. I already talked about genetics. Genetics cannot really overpower you if there is no environmental trigger. So environmental trigger means the foods that you surround yourself with. And then we have the brain-gut axis, how well your brain is able to communicate with your gut and vice versa. So the gut communicates with our brain and our brain also communicates with our gut, right? So a lot of research studies have shown that when there is lack of balance in the microorganism in our gut, it can also affect how well our brain communicates with our gut. The more balanced that your gut microorganisms are or your gut microbiome are, the better it will be for your brain to communicate with your gut and for your gut to communicate with your brain. So that two-way communication must be efficient for you to be able to know when to stop eating and when to actually start eating. That's when to stop eating. That's the fullness cue. When to start eating. That's the hunger cue. For some people, they just eat. They eat when they are feeling emotional. They eat when they are hungry. They eat just by seeing food. They eat for everything basically. That's what we call emotional eating. So just by seeing food, it overrides your normal physiological um, hunger signal, basically. So we have the epigenetics. This is the part of it's quite interesting because this theory says that how a pregnant woman feeds during pregnancy can affect how the child will process food and also respond to food. That's the part of epigenetics. That's early life programming. So what a pregnant woman eats during pregnancy can actually affect how the child will later grow up to either be obese or maybe be efficient in processing fats. So all of this can lead to adipose tissue dysfunction. Adipose tissue dysfunction means that the fat cells just keep growing, just keep enlarging, what we call hypertrophy, and that can actually lead to release of harmful chemicals, inflammation, and metabolic derangements. Next slide, please. Of course, we already know the medical complications associated with obesity: pulmonary disease, stroke, non-alcoholic fatty liver disease, gallbladder disease, cancer, skin, gout, idiopathic intracranial hypertension, coronary heart disease, diabetes, and all of that, osteoarthritis. So we already know this. Next slide, please. Right, so let's talk about the treatments. Diet and lifestyle modification is the first line treatment. I know that most of the time, endocrinologists, doctors, GPs, sometimes when they see someone that is overweight, they don't really see it as a big deal at that time. And that's the time they're supposed to actually overcome obesity. At the time, just the same way that diabetes starts from pre-diabetes. When somebody is diagnosed with pre-diabetes, and you just tell the person, don't worry, just eat less and stop drinking Coke, stop drinking Fanta, but it's actually more than that. Referring them to healthcare professionals that will actually look after them, probably create a personalized diet plan for them at that particular time, is what it means to empower them. So when somebody is coming with a BMI of 28, or even at the borderline obesity of 29, what do we tell the patients? Do you tell the patients, just eat less? Just eat less is not nutrition education. It's basically just making the person confused. Or maybe you tell them, just eat less, just reduce your intake of ultra processed food. The person will have so many questions that probably the patient will not be able to ask you because there are other patients waiting outside for you. So the patient will have tons of questions that they will not be able to ask you. So for diet and lifestyle modification, we're looking at a low carb diet, low fats, high fiber, high protein regimen, usually prescribed. And the protein intake usually between 1.2 to 1.5 gram per body weight. And that's a total of 20 to 30% of the total calories. And then fat is 10 to 15%. Carbohydrate is between 40 to 50%. Dietary fiber between 25 and 35%. That's for women, it's 25, for men, 35. Now, a dietitian will explain this in a way that a patient will understand. A dietitian will translate this into a diet plan for a patient to fully understand, take it home, go and implement it, and come back for follow-up. Then the dietitian is asking, okay, how does this suit your lifestyle? How does this suit your work schedule? I was talking with somebody recently, and she told me about how she leaves her house 6 a.m. and get back 8 p.m. She has children. She doesn't really have time to exercise. We have to now start looking at just the diet quality and minimum exercise because she is stressed. So as a doctor or as an endocrinologist, you don't really have time to listen to all that story from your patient. But dietitians have been trained to listen to all of that story. How does your work schedule affect your diet? For someone that's leaving the house 6 a.m. and coming back 8 p.m., if the person is not empowered or properly taught the art of diet quality or nutrition, the person will grab any easy food along the way, like pastries in the morning, like Coke, like anything that they see, rice, I've seen patients eat rice in the morning, rice in the evening, and swallow in the evening, rice in the morning, rice in the afternoon. They will eat rice in the morning, they will eat the leftover of the rice in the afternoon, and they will take the swallow in the evening, right? And it's just their work schedule. It's just that their work schedule does not allow them to do anything else. So that's diet and lifestyle modification. That's the first line of treatment. And then we're talking about medication when the BMI is, according to NICE recommendations. I don't really know the recommendations of the endocrinologist, but this is the NICE recommendation that when the BMI is above 30, or when BMI is above 27 kg per meter square, and there's at least one health condition, then there could be a medication as an adjunct therapy to low calorie and increased physical activity. So when the BMI is above 27 with health condition, or when the BMI is above 30 with no health condition, then there could be an indication for medication. Nutrition intervention is still very key at this point. When you're placing patients on medications, do you immediately tell them to consult a dietitian? Because most of them get addicted to these medications. They see these medications as the savior. And then when all of a sudden they start adding weight again, they become confused and frustrated. They're wondering what they did wrong, because all of a sudden the medication that used to work before is no longer very active. So they are wondering what's happening to this savior of mine, basically. That's because when you're even placing them on the medication, you're not giving them the upper hand of referring them to the dietitian. So while they're on the medication, they're not only losing their body fat, they're also losing their muscle mass. There's going to be a clash in their metabolic rates. And all of a sudden, they'll start adding the weight right back. And then we have surgery as another treatment mode. And this is always indicated when the body mass index is above 40 or more, or maybe it is between 35 and 40 with other significant comorbidities like type 2 diabetes, high blood pressure, and that could mean that probably diet and lifestyle has failed them, But in this part of the world, we don't even effectively explore diet and lifestyle. Most of the time, medications are indicated when diet and lifestyle have actually failed them. Probably it's now basically you have ruled out the environment, you have ruled out the professional help you could give them. Maybe it's majorly their genetic predisposition, and then that is when all of this can be indicated. So surgery is also the first line first line option for adults with BMI above 50. Next slide, please. So what is medical nutrition therapy? Medical nutrition therapy is an evidence-based application of nutrition care process. I've said this on this platform before, maybe that's a year ago, of the fact that medical nutrition therapy include nutrition assessments, nutrition diagnosis. Our diagnosis is not the same as your diagnosis. Your own diagnosis could be type 2 diabetes. Our own diagnosis could be excessive carb intake. Our own diagnosis could be irregular meal pattern, related to, whatever the work schedule of the person is, as evidenced by whatever we can see in their diet history, right? So our own nutrition diagnosis is not the same as your own medical diagnosis. And until you understand the nutrition diagnosis, you cannot come up with an intervention for that patient. I was talking with a doctor. I was having the presentation to one of our partner organizations, and one of the doctors said, "Oh, what about patients that cannot afford nutrition therapy?" And maybe the doctor just feel like, let me just explain nutrition to them. Maybe they're going to understand it. But in the real sense, you cannot address what you don't understand. If you don't have a nutrition diagnosis, there is no way you can address the root cause of why the person is not getting their diet right. So if you don't have a nutrition diagnosis, you cannot come up with a nutrition intervention. The best you can do is to give general nutrition advice. You will not be able to touch on the main issue that the person is facing. But dietitians have been trained to assess, to be able to reach that point of nutrition diagnosis, and then come up with nutrition intervention, and then follow up with the monitoring and evaluation. What are the MNT goals in obese patients? or with patients with obesity. Like Prof rightfully said, we're supposed to address them as patients with obesity, right? So number one is to ensure optimum nutrition status. That's the first thing. That's the first MNT goal for patients with obesity. The second one is to achieve weight loss, and the standard is for them to lose 0.5 to 1 kg per week until they reach their desired goal, or at least until 10% weight loss is achieved. Most times, a lot of research studies have shown that once between 5 to 10% percentage body weight loss, that is where they will start seeing improvements in their health. I've seen a lot of people that will tell me how they're already seeing changes in their health after 1 month of nutrition intervention, not even up to 3 months. After 1 month, you start hearing, I feel lighter. I don't feel tired like I used to. Before, when I walk this distance, I used to feel tired. But now, when I walk that distance, I'm no longer feeling tired. Even without the scale already showing them serious improvements, they're already feeling this in their body. That's because it's not so hard to get results when it comes to nutrient intervention. Right. Number three is to preserve muscle mass. No matter the medication does not protect muscle mass. The more the patient loses muscle mass, the lower their metabolic rates. The lower the metabolic rates, the higher the chance of regaining all of that weight. And of course, to ensure that blood glucose and cholesterol and other parameters are well controlled. Next slide. Next slide, please. All right. So let's talk about medical nutrition therapy in medications, right? There are medications that endocrinologists normally prescribe, the orlistats, phentermine. There are some names I might not be able to pronounce very well. Then we have the liraglutide, the semaglutide, and all of these medications have been shown to suppress appetite and food intake. The good side of that is that the patient will lose weight. The side effects of that is that the patient may not be taking in adequate nutrients. So this patient is happy, I'm no longer hungry, but the patient is also getting micronutrients deficiency, right? The patient is not getting all the nutrients they are supposed to get. So that's the downside. So the good side is no more hunger. I'm always hungry before, but I'm no longer hungry now. But now they are at risk of nutrients deficiency. Other side effects include nausea, vomiting, diarrhea, constipation, reflux, abdominal pain, and dehydration. For medical nutrition therapy, as dietitian, we try as much as possible to ensure that patients on medications are able to get in adequate nutrients within the small amount of calorie that they can take in. So most times, women can take between 1,200 to 1,500 calories. So a woman that is used to eating large before, eating up to 3,000 calories, this woman can now take 1,200 calories and feel very satisfied, or even feel too full, right? So how do we now ensure that this woman is getting enough nutrients? That's the work of the dietitian, to plan the diet in such a way that this woman is still getting all of that nutrients in the 1,200 calories, sometimes to explore supplements where necessary, just to ensure that this patient is getting adequate amount of calcium, adequate amount of vitamin D, protein, vitamin C, and all other micronutrients rather that you can think of. The minimum intake of protein is between 75 and 90 grams. We all know that this is still based on body weights. Depending on their body weight, they might need more than that. Then the fat is 20 to 30% of the total calories, of course. Carbohydrates remain 45 to 65%. And during this time that they're on medications, they're supposed to engage in strength training exercises, and the dietitian is able to check in with them. How many times did you exercise last week? How many times how well are you doing strength training? If that's dumbbell exercises or body weight strength training exercises. These strength training exercises is going to help them protect their muscle mass. And once in a while, at least once in 3 months or once in 6 months, a patient on medication should check their full body composition analysis. That means that they're able to know their bone mass, their muscle mass, their body fat percentage. They will be able to know if their muscle mass is reducing or not. They're also able to during the body culture analysis, they're also able to check their resting metabolic rates, beyond using Mifflin-Geor's equation. The full body culture analysis help them to really, really detect if their muscle mass is going down or if their bone mass is actually coming down. Next slide. So practical management of GLP-1 patients for dietitian, that is initial assessments. These initial assessments include review of their medical history, review of their diet history, maybe recent surgical history, anything that pertains to their medical history are being reviewed. And of course, like I said before, we reach a nutrition diagnosis, we come up with the personalized diet. Now, before the personalized diet plan, it's always good to check the body composition analysis. I've said this before. And before coming up with a personalized diet plan, then there is the follow-up sessions. The follow-up sessions is to make sure that the patient is actually getting adequate nutrients. And you're also empowering the patient. Most of the time when patients go on medications, they just think that they don't need to exercise anymore, or the medication is the answer to everything. So they don't need to exercise. They don't need to really, really watch what they eat. That medication is a savior, basically. That's the way they see medications. And that's why you now see unlawful sales of the medications, help flying everywhere. Some people say, I have Ozempic, I can sell it to you. And then people just keep buying. That's because they are seeing it as a savior. They're not even looking at themselves as people that can be empowered to take control of their health. When they come for follow-up session, they are advised on how they can still maintain portion control, how they can still control their portions, as well as maintain physical activity, such that when they go off this medication, they are not gaining back all of their weight. So that's the aspect of mindful eating education, stress management as well. How do you respond to stress? Do you respond to stress by eating, or do you respond to stress by exploring other factors that can actually help you to reduce your stress level? Next slide, please. Medical nutrition therapy in post-surgery. Of course, we know that we have the gastric sleeve and the gastric bypass as the main surgeries, and both surgeries involve removing portion of the stomach that produces the hunger hormone. So basically, the patients, that solves the problem of excessive hunger, right? Both surgeries also are more, when it comes to weight loss, they are more long-term compared to medications. And bariatric surgery is effective at improving metabolic dysfunction related to visceral fat. But lifestyle is still very important. Lifestyle or healthful diet is still very, very important. The goal here for dietitian is to establish a balanced, nutrient-dense pattern for sustainable health. And immediately after the surgery, we have progressive diet, from clear fluids to full liquid diet to soft solid. And then the calories are usually between 1,200 and progress gradually to 1,800, depending on what the patient can accommodate, or depending on what the patient needs based on the calorie calculation or requirement or estimation. The protein intake is usually between 70 and 100 grams per day, and that's between 1.1 to 1.5 grams per kg body weight. And then we also ensure as dietitians that the patient is getting enough servings of fruits and vegetables, usually 5 servings per day or more. And then micronutrients is also very important: B vitamins, calcium, vitamin D, zinc, iron. A retrospective study of 220 patients who underwent bariatric surgery between September 2015 and June 2020 found that 3 or more registered dietitian visits during the first 12 months. I'm still on the previous slide, please. This study found that 3 or more registered dietitian visits during the first 12 months after bariatric surgery are actually linked to or associated with improved outcome, including significant percentage body weight loss and lower rate of micronutrient deficiencies. Next slide, please. So it is very important that after the surgery, you bring in the dietitian to estimate the calorie need of this patient to initiate the progressive diet, initiate supplements where necessary, so as to optimize the nutrient intake of the patient. The timeline for this table is the practical management of a bariatric patient. Week 1 to 3, that's the week 1 to 3 post-op. That's when there is immediate post-operative diet progression, and there is also supplement initiation. And this usually take about 2 visits. Then between months 2 to 3, we have the texture advancements. That's when you move to solid. You are ensuring that this patient is taking in adequate protein. We're also basically we're managing side effects basically, and that is 1 visit per month. So for just once a month, this patient is expected to see a dietitian. And then at month 6, we have the body composition analysis, lab review, micronutrient assessment. That's 1 visit in 3 months. So a patient that's just undergo the bariatric surgery is meant to check their body composition analysis once every 3 months, then later once in 6 months. Then the 12 months, we have the long-term weight maintenance. I'm almost done with the last slide. All right, yeah. Long-term weight maintenance, weight regain prevention, annual body composition analysis, resting metabolic rate analysis, and lab review. Next slide, please. And that's a total of 6 visits to a dietitian over the course of 12 months. Right, so practical management of a patient, of a bariatric patient, sorry, this is a typographical error. The pre-operative nutrition assessments are usually overlooked, but this is the best time to bring in the dietitian, usually 4 weeks before the bariatric surgery for in-depth nutrition assessment. And then we have the post-operative progressive diet initiation. I've talked about that. Early post-operation check and supplement initiation, gut health review, diet history, and nutrient intake optimization. Then moving on to body composition analysis, personalized meal plan, lab review, mindful eating education, and structured follow-up. Next slide. As endocrinologists, it's very important that we embrace the multidisciplinary approach. We cannot do all the work. At what point should we refer to dietitians? The first point is the new diagnosis of obesity. When the person is just 29 or 30 kg per meter square, that's the best time for you to refer them to see a dietitian so that they will be empowered, so that they will not get to 35, 40 and above before they now start thinking about their surgical options. So at the point of diagnosis or when there are obesity-related conditions like diabetes or hypertension, refer to the dietitian. Number 2 is when you're just starting medication. Immediately you place a patient on medication, refer them to a dietitian. 3, at the time when you're about to schedule the bariatric surgery, that's the best time to bring in the dietitian as well. Post-bariatric surgery is another one that's immediate and ongoing. You basically allow the patient consult the dietitian for 1 year after the surgery. This will empower the patient, literally. It will empower the patients to know how to eat for their health. And number 5 is when there is a plateau or a weight regain on current treatment. Maybe you have placed this patient on medication and the patient was losing weight before, and now the patient is no longer losing weight or probably has started regaining the weight. That's the best time to refer to a dietitian. And lastly, if the patient say, I'm confused, I don't know what to do. I don't know what to do about my weight. I'm confused as to what to eat. That's the best time to tell the patient to consult a dietitian. Next slide. And of course, in our diet clinic, we have the standard nutrition care plan. We have the premium, we have the VIP. The premium and the VIP, that is where the patients can do the full body composition analysis. That's for patients that are in Lagos. For patients that are not in Lagos, they can simply go for the standard nutrition care. And of course, there'll be estimation of their energy requirements. But for patients that are probably on medications or probably being prepped for surgery, then they will need full body composition analysis and that's under our premium and VIP nutrition care. Next slide. I'm trying to rush so that I'll finish on. And we have reviews. I cannot read all of them, but you can type Carotid Clinic on Google. You see lots of reviews. A lot of people have been able to lose weight on our plans effortlessly. They have been able to reduce their blood cholesterol levels, reduce their blood sugar levels effortlessly on our plan. So it is very important that as healthcare professionals, we help these patients. Most of them are confused. You can just help them by referring them to registered dietitians. Thank you so much. I can have questions.
Thank you, Olajumoke, for your extensive and enlightening presentation. I think that we have gotten a re-emphasis on the fact that obesity is something that we cannot ignore, with 2.5 billion people being overweight, 890 million people currently living with the disease, and more than 39% of adult Nigerians either obese or overweight. But more than that, you took us to town on the dietary importance with patients that need to lose weight, the benefits of it, and the role of MNT. Thank you very much. If you have any questions, please put up your electronic hands or place the questions in the chat group. Dr. Lopade, over to you.
Thank you, Dr. Adeze. So please, if you have questions, you can raise your hand and we'll acknowledge that. The question is to be directed to the first speaker and the second speaker as well.
Yes.
I thought the third speaker should also get questions.
Yes, sir. It's to everybody,
Yes, sir.
all the speakers. Really. So let me just start by saying, and to Professor Gezawa, I don't know, how do we change this narrative, food as love? Because that's part of one of the things I picked in your presentation. Don't you think it to be insultive to begin to turn down our mothers who offer us food? I don't know. This is a long age cultural behavior. And when you accept food, it's as if you accept and you respect them. So how do we change this narrative?
Okay, thank you for that question.
Okay.
Yes, I can hear. Thank you for that question, Dr. Olopade. I think one of the best ways is to educate them, make them aware of the fact that, overeating can cause obesity, and obesity has a lot of complications that can actually be fatal in some occasions. I think by trying to, make them aware of the implications of overeating or unhealthy eating, I think somehow they will be convinced, that, probably they should stop such cultural practices. That's my own view.
Okay, so I agree with that, but I'm just looking at so my other question to you, sir, is
in a respectful
manner, because it's going to
ethical manner. Yes,
Okay, let me just quickly
our
ask this.
parents, we must always be careful with them.
Yes, we must be careful.
Not annoying them.
Okay, so in this age now, because we're talking about system changes, if you look at the landscape is changing, people are working from home now, remote jobs. So what do you advise people who work remotely and are struggling to lose weight?
Well, I mentioned that, long, sedentary lifestyle, there is no way you can, perpetually, practice, sedentary lifestyle or be sedentary and then expect yourself.
Professor Gezawa, you are muted again.
Sorry. Okay, maybe you didn't hear. I said
no, we're hearing you now.
Yes, you wouldn't expect, yourself to be sedentary and then expect to lose weight. Okay, Physical
Yes, I
activity, yes, physical activity is a major way of burning calories and then losing weight. Even if you follow a healthy diet, but you are sedentary, okay? You are sedentary. It is not likely, you will definitely put on weight, because in that case, you are not, what will I say? You are not burning the excess calories that you do not, because you are not doing any activity. Okay, so that's the issue of accumulating calories and getting fat will still be there. So physical activity is a necessary part of lifestyle modification for one to lose weight.
Okay, thank you so much. Abuchi Okaro, your hand is up. You can go ahead.
Oh, hello. Can you hear me?
We can hear you.
Yes. Good evening, everybody. I'm a surgeon. I'm actually the current president of the Nigerian Metabolic and Bariatric Surgeons Society of Nigeria.
Oh, that's good. Nice.
Yeah. So
We are in Kano. Nice to see you.
correct, Prof. Thank you. Yes, we were in Kano. You hosted us last year. Thank you.
Yes.
So I wanted to obviously, I think, thank everybody. All the talks were, I think, extremely enlightening and, of course, on point for this important day. And I suppose that what I wanted to do was to maybe share some challenges we surgeons are having when it comes to awareness, and of course, just general patient engagement, and merely to seek everybody's support. Now, it's clear that there are many, many categories of patients who have the need for help, ranging from the very low BMI to the extremely large BMI. And of course, we know GLP-1s have their impact, but they also have huge limitations in the super obese. So it's clear surgery is much more effective. But we have problems in Nigeria around awareness, firstly, not just within the communities, but also within the healthcare space. We have issues of affordability, access, and of course, safety. So there are many reasons why this type of surgical involvement is limited. There are many reasons. So I think the thing I wanted to say is we are definitely making inroads, as in Nigeria has, we had a meeting in West African College of Surgeons last month in Accra, and we looked at all our data because, we've been doing surgeries in Nigeria for, maybe 12, maybe 14 years, and our numbers are highest in West Africa. I recently published a paper in one of the Pan-African journals, outlining some of my own personal results. So what I'm saying is that for the right patient, I really still struggle to get referrals, not just the diabetics or the hypertensives, but just the people who are just overweight with knee joint problems. So we're trying to encourage people to talk about it for the small numbers that would be considered for surgery, small numbers comparatively to the volume of the patients. So my question really is, when do my endocrine colleagues really consider referring for an opinion for surgery? What's the indicators? Is it BMI? Is it HbA1c? Failed medical therapy? What are the clear classic guidelines in the Nigerian Endocrine Society? What are our guidelines? Or do we have guidelines like we have internationally? And if we haven't, maybe we should consider it. But anyway, I'm sort of asking questions and commenting at the same time. But maybe the big question is, do we have any guidelines in the Nigerian Endocrine Society that suggests surgery should be considered under certain conditions as it is internationally? If not, should we have them? And number two, when do the other endocrinologists refer personally in their own personal practice?
EMSON.
I don't know if you heard me.
Yes, loud and clear. And Professor Gezawa, do you want to answer?
Yes, I wanted to say that for the issue of guideline, our recent guideline that we launched at the last EMSON, contains a section on the weight management, though in patients with diabetes, but then it captures, the indication for bariatric surgery. In fact, at the committee level, because we looked at other guidelines, we debated very much on which BMI cutoff should we adopt, and those that were against lower BMIs, say, well, if we lower the BMI cutoff, then it means most of our patients will be referred for bariatric surgery. So I think we raise it a bit. I think it's 40 kg or even 35, but with comorbidities. And I think that is a standard thing, in many guidelines.
Yes.
Either the BMI as a whole, or the presence of comorbidities even with lower BMIs. And in fact, I read somewhere that people are now looking at.
You're muted, Professor Gezawa, as you're talking.
Okay, hello, can you hear me now?
Yeah, we can hear you now.
Yes, we can hear you. Yes.
I hope you got my last point where I mentioned the issue of, yes.
You said you read recently. That's what we heard.
You said?
You read recently. You read recently.
Yes, I read recently somewhere that, because if you look at it, some of the changes that take place following bariatric surgery, are they really even dependent on the weight loss itself? Because it's been observed that some of the changes occur even before the patient starts losing weight. Let's take, for example, resolution, reversal of diabetes. Many patients, because in Kano, we do a group practice. I do a group practice with Dr. Usman, the bariatric surgeon. So I saw a lot of patients who immediately after sleeve gastrectomy, within a week or so, they are off their anti-diabetic agents, and that's when they have not even started, losing weight. So the issue of the BMI cutoff for referring patients for bariatric surgery is something that probably in the future may need to be revised. But for now, I think our guideline, what it says, is that, we adopted the 40, or even 35 with comorbidities as one of the, indications for referral for bariatric surgery.
Okay.
I didn't get the second question. I think there are two questions.
No, I think the second question was really more of a personal one.
Okay.
What I meant by personal is that, the endocrinologists that are there, when do they consider it? And maybe the bigger question is, what are the barriers? What are the things that make them more reluctant or less inclined to consider discussing it with patients? Or in response to a question from a patient, what would their view be? It's more of a personal sort of.
But I would say just a quick, one of the barriers, I think, number one, I don't know, it depends on the environment you are living. If you are in Lagos or Abuja, you have very rich patients, so that shouldn't be a problem. But somewhere like down north, as soon as you tell them how much, it will cost them to have sleeve gastrectomy, that is one of the factors. But a few of them, of course, still will go ahead and pay. But I think that is a major barrier, actually, the cost.
Yes.
Cost of the surgery. Yeah.
I agree.
Okay.
Then lately, another thing has emerged in my experience in Kano. There was this actress in Kannywood, who had bariatric surgery, and she became so slim. In fact, she had her surgery in Egypt. She became so slim that, some of my patients that can actually afford the bariatric surgery
Get worried.
Whenever I talk to them about this, I don't want to be like,
Yeah.
I don't want to be like that person. So, in fact, some have started, they've now realized the difference between sleeve gastrectomy and, say, bypass surgery. Because I had this patient who had bypass in Dubai, and then later she said she lost so much weight, she wasn't happy with the way she was looking, and that she had to go back for the surgery to be reversed. So some patients have started looking at, maybe bypass will be better because I can reverse it if I'm not happy with the eventual, my new weight after losing weight after the surgery. So
Interesting.
that is something that is emerging now. Yeah.
That's correct, Prof. Thank you for that. Thank you.
Thank you so much. Let me allow Dr. Ashibu to respond. Is he respond or you want to ask questions?
Yes. No, sir. I want to respond from the part of pediatrics. So thank you very much. It was good to hear from a bariatric surgeon. Actually, Professor Fasomade had asked this question before
Yes.
he exited. So for us in pediatrics, yes, failed conservative treatment, but we look at the period of 6 months before we consider that. So 6 months of failed conservative treatment. Then the BMI too, when there's severe obesity. So BMI greater than or equal to 35 kilograms per meter squared, or if it's extreme, on the extreme side, greater than or equal to 40 kilogram per meter squared. But of course, we have to plot it on the centile chart. So 120% of 95th centile, yes, they will go for bariatric surgery. But then the thing about children is that we need them to be physically and mentally mature, in the sense that we need them to have completed their growth to an extent. So it doesn't go for anybody less than an adolescent. So it's adolescents that we consider for that, who have had failed treatment, who have had complete growth, at least standard stage 4 to 5, and then who are not having any mental challenges. So no depression, no anxiety, and none of such. We can actually use them for that. And then lastly, we have to ensure that they don't have any of the obesity syndromes, especially not Prader-Willi syndrome. So once we are clear the air on that, then they can safely be sent to them. Thank you, sir.
Thank you so much, Dr.
Thank
Ashibu.
you.
Professor Olamoyigun, please go ahead and ask your question.
Okay. So good afternoon, everyone. I want to join others to appreciate all our presenters for the wonderful presentations. It's just a comment, and my comment is directed to the dietitian. That was a wonderful presentation, but I want to correct an impression. And the impression is that maybe, yes, endocrinologists, just like other doctors, may not have sufficient time to educate patients because of the number of patients that we see in our clinics. But to say that we are not well equipped enough to be able to manage patients on nutrition is not true. Nutrition is a significant component of endocrinology training. And so we are well versed in dietary management, not just of diabetes, not just of obesity, but other medical conditions. And we also have an advantage. And that advantage is that when we see patients, we have their laboratory results that can enable us to adjust their diets based on the results that we have. For example, we have their lipids. We know those whose lipids are very high, and we need to prescribe diets that is related to the level of the lipids. Same with their kidney. We have their kidney functions. So we know the stage of the chronic kidney disease, where they are, or their kidney status. And so we can prescribe based on their kidney level. So, but we don't have enough time because of the number of patients that we see. But to say that we might not be well placed to prescribe diet or to teach patients about nutrition is not completely true. Now, this does not mean we don't appreciate what dietitians, what they are doing, or taking over their work. We can only complement each other. But the training of endocrinology is such that we are well versed in nutrition. Thank you very much.
Thank
Thank
you
you.
for the clarification, sir. I also would like to, I'm also curious to know how, by being equipped, I was talking from the perspective of medical nutrition therapy. So I'm curious, are you also trained on how to arrive at nutrition diagnosis and how to come up with a nutrition intervention?
Do I go ahead, Dr. Lokpade, and answer?
Go ahead. Go ahead.
Yes. So even in medical nutrition therapy, I may not be able to speak for everybody, but I know it's a significant component of endocrinology training. And I can tell you that I'm well versed and speaking as an individual on medical nutrition therapy. I can break down what patient is going to take up to the number of grams and all of that. And I think it's almost true for all endocrinologists. But that may not be true for all medical doctors, you know. So I can't speak for surgeon, I can't speak for other people. But endocrinology nutrition is a significant component of our training, including medical nutrition therapy.
I'm just talking from the perspective of reaching nutrition diagnosis, assessing a patient to the point of coming up with a nutrition diagnosis. Because when the diagnosis cannot be reached, you cannot develop a nutrition intervention. Medical nutrition therapy is beyond breaking it down into prescription down into grams of food and not. You can come up with grams of food. You can come up with a prescription, and your patient will not follow it if you don't have a nutrition diagnosis. That is my point. Right.
No. I just use that breaking it down to let you know the extent. So to establish diagnosis of what is responsible for obesity is not a problem. It's part of our training. Maybe so we don't waste much time, because I know the time is limited. Maybe anytime we have physical contacts, you know, we can exchange idea to know the extent to which I'm talking about.
Yeah, because in the real sense, if you can come up with a nutrition diagnosis, if your job allows you to come up with a nutrition diagnosis, then there won't be any need for us. So if you can come up with nutrition diagnosis, create meal plan for your patients, create prescription for your patients, you basically don't need dietitians.
And thank you.
Let me intervene. Sorry, Dr. Olopade. Thank you very much.
Yes.
Yeah, so the point is that we complement each other, and to say you don't need a nutritionist or a dietitian as part of your management team will just be something similar to saying you don't need a nurse in helping you to support the care of your patient. I think the point that Professor Olamayogun was trying to make was the fact that our training is actually all comprehensive, and you wouldn't be certified a competent endocrinologist without sufficient grounding in medical nutrition therapy. That's the point. And so in some centers and in some countries, the name of the specialty is endocrinology, diabetes, metabolism, and nutrition. That's just for our enlightenment. So no matter how highly enlightened or informed or skilled we are in issues of medical nutrition therapy, it does not remove the place of the dietitian or nutritionist in the management of the patient. We complement each other, and it's a multidisciplinary approach, and that is what is preached. I would like to thank the presenters. Quite interesting discussion this evening. The aspect I wanted some insight from Mrs. Olajumoke is the experience with working with clinicians, particularly in the University College Hospital, and not in the private place. In fact, I'm going to charge you money for advertising on this platform. Now, in the University College Hospital, what's your experience working with endocrinologists I speak directly for endocrinology because that is what we are, and that's what we promote. And then generally, with clinicians, do you get to join their award rounds? Do you get to participate in the diabetes clinics, for example? Do you get referrals? Do you do a two-way referral between the clinicians and the medical nutrition therapy unit? Do you get to interchange ideas? Do you hold from time to time discussions, academic meetings, seminars where you exchange ideas and things like that? Do you do collaborative research? All of
That's
this, they bog my mind, and for practical purposes, so that if we get a good model, for instance, in University College Hospital, Ibadan, we could begin then to say we want to generalize to other centers in Nigeria. I want your comments, Mrs. Olajumoke, but your lecture was a great one. Thank you.
Thank you. Thank you so much, sir. I'm already part of EMSON, so you cannot charge me for advertisement.
Oh,
I'm
that's great. That's great.
member. All right, sir. I I am no longer in the public sector. I did my IT in I did my IT at the University College Hospital. I had the best experience there. At that time, I've not even finished my undergraduate studies, and we go on world round with senior dietitians, even from the time when I was an undergraduate. I did my internship at LUTH, that's Lagos University Teaching Hospital, and the experience was amazing too. For both UCH, I have experience in both UCH and LUTH, and the referral system is amazing. We receive referrals from every sector, not only from the endocrinologist, but from the emergency ward, the bones unit, every sector, the pediatric units. The referral system is amazing, well structured, and dietitians are fully integrated into all of the management of all conditions, not just the diabetes management, but all conditions that are nutrition related. So yes, I had an amazing experience in both UCH. I'm no longer there. I'm no longer in UCH. I'm no longer in LUTH. I run my own private diet clinic in Lagos. I'm in Lagos, right? But the experience there, the experience I got from both university teaching hospitals are just amazing. The referral system there, amazing. I don't know much about the private sector, but for those two teaching hospitals, I'll just give it to them. The referral structure is really good.
Thank you very much. Professor Gizawa, I don't know what your experience is with difficulties in some individuals to lose weight despite doing everything. They do the lifestyle, i.e. diet, exercise, they observe all the recommendations, yet the weight is not going. I need your comments on that. And then to the bariatric surgeon, we are happy that you were able to come to be part of this talk. And I'm also happy you quickly summarized the challenges with bariatric or metabolic surgery here in Nigeria. Of course, we quite often want to differentiate between metabolic surgery and bariatric surgery, meaning one is not actually so much about the weight, but more about preserving a healthy metabolic milieu. What do you advise, or what advocacy do you do in trying to create awareness that bariatric or metabolic surgery is not for the very rich and the very affluent? Are there considerations for subsidy or waivers for patients? Sometimes your charges are just prohibitive. That is the truth. And we know it's a highly specialized surgery. But then, is there anything your society is doing towards making it more affordable to the average Nigerian? You asked questions about guidelines in Nigeria. I'm happy with the responses that Professor Gizawa gave you. But at the Endocrine and Metabolism Society of Nigeria, we have a new drive towards documenting evidence-based guidelines for Nigeria for the major endocrine illnesses. And very soon, we are going to come up with an obesity guideline for Nigeria. It's something on our table that we are thinking about, and by then, it will complement what we already put down on the diabetes guideline. The diabetes guideline, by the way, is a published material, and it can be Googled and researched. Thank you very much.
Good. Thank you. Thank you for the, I suppose the question was directed to the surgeon in the group, I think. So yes, I think that's probably me. So yes, no, Dr. Caro, I hope you can hear me. I think I'll probably start by commenting that I think it's nice to know that there's adjustments going on around guidelines that are a little bit more practical and more representative. So I look forward to kind of receiving those. On the real big question about access and affordability, let's be honest. The Nigerian healthcare system in all its levels has huge issues around access, particularly around things like costs and remuneration. But the bit that's always been we've been keen on is that in this type of approach, my attitude has always been, or at least my consideration has always been that, you have to start in a model that is sustainable. But more relevantly, you need to be able to make sure it is delivered with the standards that are high enough to meet international maybe criticism or consideration or review. And that is a big task for these patients who are obese and maybe have hypertension, diabetes, or whatever. They're very difficult patients. They're difficult to anesthetize, they're difficult to operate on, and they are absolutely difficult when they get into bleeding or any other complications. So the simple answer is, unfortunately, getting this available to those that can't afford it is still a challenge for us. Our numbers don't even make it possible that there is enough profitability in it to open it up, let's say 1%, 2% at this stage. However, some of us remain optimistic that as the numbers and referrals from those that can pay grow, and the funding and support from industry, particularly some of the companies, big companies that produce all these equipment that cost so much money to do the surgery, that should change. But equally, with all the emphasis that is going on in the Nigerian kind of corridors of power around insurance, around obviously making things more accessible to the Nigerian people as part of our economic growth, I think that might be included. So unfortunately, no, we haven't really been able to set up any good quality foundation yet. But I am hoping in the years to come that should be the case. I'm hoping so.
Thank you very much.
Thank you, President.
I think I have a question.
Okay, go ahead, sir.
Yes. Okay, I think the question was that the patient that was virtually doing everything right.
Yes.
And then on medications, if I can remember, but yet the patient is not losing weight. Was that the question, Professor Loco?
Yes, that's the scenario.
Yes, the patient is on pharmacotherapy, and then he is following all the lifestyle measures, yet the patient is not losing weight. Number one, you have to look at the duration of treatment. How long has he been doing that? And then number two, if he has been, taking the medications or injecting the GLP-1 receptor agonist, remember I mentioned that it's in the first 6 to 12 months that the patient begins to, rapidly lose weight before it now plateaus, and then the rate slows down. All right. If he has not been, injecting the GLP-1 agonist for up to 6 months, probably you may need to wait until then. But if he has also done that, yet he is still not responding, then you need to look at barriers, such as side effects, of the medication, and then whether or not, the patient is really, I don't want to use that word because we discourage it, compliant or not. And then if that is not the case, then, as I said, and that is the meat of my presentation, you have to also consider environmental risk factors. I mean, yes, environmental factors. As they say, medications work best when combined with community support, as well as, advocacy for policy change where possible. So most of the things, those pillars that I mentioned, need to be taken care of for your medication to work. All right. So those are the steps actually that might need to be taken.
And let me jump in, Prof, and finally add, please consider surgery. About 10% of my patients.
Yes,
Honestly,
after you have excluded all these factors,
exactly.
surgery will be
Honestly,
the
10% of my patients, both here in UK and in Nigeria, have reacted to GLP-1s and have had surgery and lost weight. So we can't ignore that fact. Seriously, surgery is still the pillar.
Definitely.
Well, yeah, please.
I agree with you. Yeah.
Thank you. Thank you.
Yeah, I also agree with Dr. Okaro on this. After you have done all you can do, surgery, yes. And then, of course, sometimes a further evaluation for other comorbidities that are not so commonly seen. Thank you so very much for all the inputs. I appreciate it. It's a great learning evening.
Thank you. Dr. Nkechi Johnson.
Thank you.
You're raising your hand. Dr. Nkechi Johnson, can unmute yourself and ask a question.
Okay, good evening. Can you hear me?
Yeah, we can hear you.
Okay, good evening to the moderators. My name is Nkechi Johnson. I'm a public health nutritionist, also a dietitian in the School of Public Health, Uniport. Well, it's been an interesting section. I'm just not so happy that I joined in late. But why I said it's an interesting section is when you join a lecture at any point and then you're able to understand with the presenters, able to reason, you know that section was quite interesting. So a special thank you to the facilitators, the presenters, though I wasn't here during the presentation. I want to make a little input, and that was on what I had, the discussion I was hearing when I joined in. I think dietitian Jumoke was talking about, I don't know if it was an argument, or let me put it that she with the other professor were talking about dietitians and maintaining their lane. Let me generalize it this way. Now, I think as an endocrinologist, you have good knowledge of nutrition. I've worked with endocrinologists and I see that they have knowledge of nutrition. However, as nutritionists and dietitians, we are specialized in dietetics. Okay, so there is no comparison, just as Prof. Loko said, that we complement each other. I totally agree with that. We complement each other. Now, let me give a little hint. Part of our training in nutrition and dietetics, we learned anatomy. I had about 4 sections of anatomy and physiology, but that I passed the course very well. Likewise, some other people that had that did the course, and we cannot say we are anatomists, despite the fact that we were exposed to a lot of some of the medical courses. Okay, so that we had the knowledge does not make us specialists. And yes, you were talking about asking Jumoke how the referral system is in UCH and Ibadan and Lagos or something. Yeah, if that is for UCH, I think it's good. But my little experience with the referral system in in UPTH was not so good. I did my internship there, worked there briefly, but believe me, the problems I see with their referral system is it's quite horrible. Most of the times when doctors refer patients to a dietitian, you see that it's either the patient is long gone or the next thing we hear is, it's quite annoying. The referral system is very, very horrible at UPTH. So that's my report from UPTH. And I wish that something could be done. Though dietitians there have complained, there have been a series of complaints, and they were also having internal issues. Yes, I know. So yeah, that's my report from there. And thank you. That's just my little contribution. Thank you so much again and for this wonderful section. Thank you.
Yeah,
Thank
very
you.
quickly. Sorry, Dr. Olopade, this is a very important point that she is raising. And Dr. Adezi, you are on this call. Whatever it is that is going on at University of Port Harcourt Teaching Hospital that is making this observation that the referral system in that place is not good enough, please take this message back to colleagues in UPTH that they need to do an improvement of what is supposed to be standard. And the standard is that we work with dietitians, we work with them in the ward rounds, we work with them in the clinics, we have meetings together to discuss cases and clinical issues, to sort these things out together. In fact, as a matter of fact, as you know, endocrine residents take rotations in dietetics and medical nutrition therapy, and they must be signed up for that to be found eligible for appearing at the Part 2 postgraduate examination in EDMN. So we are a bit concerned that this is coming out. Something that can be well adequately tackled locally. Please take the message back that at this meeting, this matter came up and we wanted something done very urgent.
So,
I beg to say that this is not the picture across the country. Just like the presenter Olajumoke talked about her pleasant experience in UCH and Lagos. Thank you.
Sir, if I may respond, can I respond to the comment? Okay, so I'm curious first to ask Dr. Nkechi if she worked in UPTH at any time and what exactly were the challenges for the dietitians, because it's not just enough to speak on challenges, but to specify what the challenges were. I'm not aware of this. That's one. Number two is that concerning the collaboration in terms of MDT treatment for the patients. We have a dietitian that is on ground, that's dietitian Peace. She has a PhD in dietetics and nutrition, and she works closely with me. At least this is what I am sure. I am not sure about other departments or other units in the hospital, but when it concerns the EDM unit, we run Monday and Wednesday clinics, and a dietitian comes and has a specified office in the diabetes clinic, which holds on Wednesday. So we directly refer the patients that require dietary counseling to her. There's also dietitian Echefu, who is the head of the unit for dietetics. So I'm really, really surprised about this. The only thing that I would say is maybe perhaps we do not have a combined ward round, because the dietitians do their ward rounds independent of us. And that is after we have referred patients to them, or if other units have referred to them based on the needs of that patient. So this is news to me. I'm not sure, but if it is possible, I would like her to specify what the specific challenge is, because I'm not aware of it.
So maybe you will meet outside this meeting and get it sorted out. Thank you.
Okay, thank you.
Yes. Thank you, Professor. I want to thank Professor Gezawa and other speakers. I am just wondering how we can also play the role of advocacy on obesity. And since Professor Gezawa, you are the leader of the obesity study group, so I think we should begin to put up points that you've presented in this meeting together, and how we can present it at maybe House of Assembly or to any of our legislators, how we can help the systems to change for good, how we can claim all those green spaces that are evaporating from our environment, how we can get them restored. I know in the past, you mentioned about car-free days. There were days where odd even number were on the road in Lagos and odd numbers were on the road the other day, but that is no longer in place any longer, or it's no longer implemented. So these are things that may consider. So thank you. I don't think there's any other question. So if there's no other question, Mr. President, I don't know whether to give a closing remark or should I go ahead and give a vote of thanks?
Just to quickly say that while appreciating everybody on a day like this, ordinarily, we should have an EMSON position statement on overweight obesity in Nigeria. It's not too late to do that. At the Secretariat, we will coalesce all the salient issues raised, particularly the fact that we emphasized on system improvement in the care of our patients with overweight obesity and the concerns we have about the growing epidemic of overweight obesity in Nigeria. And then do a paper or a position statement that will be published in any of the dailies in the coming few days. That's a very important take home from this discussion. Otherwise, I'd like to thank everybody for finding time to be part of this meeting. It stretched for this length of time because hackers came on board, and to the glory of God, we were able to do away with them, and we had a good meeting. Thank you.
Thank you so much, sir. So to Dr. Kemi Ashibu, Professor Gezawa, Mrs. Sonia, I want to say, and to all esteemed members of the society, our elders, our beauty, I want to extend a heartfelt vote of thanks to every one of us for participating in this World Obesity Day. And I want to say thank you for your valuable insights, expertise, and contributions that everyone has made to the success of this program. We appreciate your time, your dedication, and commitment in the conversations we've had. I want to also appreciate those who are visitors in our midst, the president of the Bariatric and Metabolic Surgeon, Dr. Caro. Thank you for gracing us with your presence. And we believe your involvement has helped to shape and bring about a meaningful discussion. Thank you so much. And thank you everyone for being part of this program. We hope to have you again when we have that program. So thank you. You have a lovely.
Bye-bye. Thank you.
Bye. Thank you, sir.
Good night, everybody.
Thank you, everyone.
Good night, everyone.
Thank you. Goodbye.